Good morning, everybody. This is Mrs. Beaver, and I am going to go ahead and start your diabetes lecture. I'm going to split it up into two parts. So today we'll be talking about what diabetes is and some of the complications that can go along with that. The pathophysiology here is diabetes is a chronic disorder of impaired metabolism with vascular and neurologic complications. The key feature here is elevated blood glucose called hyperglycemia. Blood glucose levels normally are regulated by insulin, a hormone produced by beta cells in the islets of Langerhans located in our pancreas. The patients here with hyperglycemia are going to be at an increased risk for heart disease, kidney disease, blindness, amputations, and complications during pregnancy as well. But not now with better management options, it's possible to reduce those risks. So in healthy individuals, a small amount of insulin is actually secreted continuously. That's called a basal secretion. It's where insulin is moved into the bloodstream just at a continuous motion. The ingestion of carbohydrates then also triggers an insulin secretion, but in larger amounts, and that's actually going to be called a bolus secretion. And then we have two insulin types. They're called endogenous and exogenous insulin. Endogenous insulin is insulin that is actually produced in our own body, meaning that it's produced internally. And then exogenous insulin is insulin that comes from other sources and is administered to a person, meaning that comes from an external source. So that's going to be like insulin injections for your patients. And this is just a picture of what your pancreas looks like and the arteries of the pancreas and the spleen. Our pancreas is a long, slender organ that lies transversely across our upper abdomen, extending from the curve of the duodenum to the spleen. It's 6 to 8 inches long in adults. It has two functions. They're endocrine and exocrine functions. So they aid in digestion. They produce digestive enzymes. And then they have a hormonal function that secretes two hormones to regulate our blood glucose levels, and that is insulin and glucagon. So in the pancreas, we have the islets of Langerhans. These are hormone-producing cells of the pancreas. They constitute 1 to 2% of the mass of the pancreas, and each islet contains a few thousand cells and is 0.2 to 0.5 millimeters in diameter. The alpha cells here produce glucagon, which converts glycogen to glucose. That raises our blood sugar level. And then the beta cells produce the insulin, which causes glucose to move into the cells from the bloodstream to then lower the blood sugar levels. And then we have delta cells, which secrete somatostatin and gastrin. So the roles of our insulin, the first role is for glucose. Insulin here is considered a critical hormone for glucose metabolism. It stimulates active transport of glucose into the cells. So if insulin is absent, glucose remains in the bloodstream, and then it becomes thick, which increases its osmolality. And then the increased osmolality here stimulates the thirst center. And then increased fluid does not pass into the body tissue, so we have a high serum osmolality, which retains fluid in the bloodstream. And then as blood passes through the kidneys, some glucose is eliminated, which we know that glucose should not be eliminated into our urine. So the osmotic force created by glucose draws extra fluid and electrolytes with it, causing abnormally increased urine volume. So the increase in the thirst center that our patients here have is going to be polydipsia, and then polyuria is excessive urine. And then their patients may also become excessively hungry, but they can't use that extra glucose without their insulin. That excessive hunger is called polyphagia. So insulin regulates the rate of glucose metabolism. The greater the insulin response to carbohydrate ingestion, the faster carbs are metabolized. So in a healthy person, when our blood glucose falls, insulin production is then inhibited and stored glycogen is converted to glucose by a process called glycogenolysis. But then when our blood glucose levels rise, like when we eat a meal, insulin production is then stimulated and the conversion of glycogen to glucose is inhibited. This process usually maintains a blood glucose level within a normal range. However, when insulin secretion by the pancreas is not sufficient, glycogen is converted to glucose in an attempt to nourish glucose-starved tissues, but hyperglycemia occurs because the cells cannot use the glucose. Another role of insulin is fatty acids. Insulin in the role of fatty acids promotes fatty acid synthesis and conversion of fatty acids into fat, which is stored as adipose tissue. It also spares fat by inhibiting breakdown of adipose tissue and mobilization of fat, and by inhibiting the conversion of fats to glucose. Without adequate insulin, fat stores break down and increase triglycerides that are stored in the liver. Increased fatty acids in the liver can triple the production then of lipoproteins, which promotes atherosclerosis. So this is why people with diabetes have a high incidence of cardiovascular diseases. And then the role of insulin in protein. This enhances protein synthesis in tissues and inhibits the conversion of protein into glucose. Amino acids are admitted into cells, an enhanced rate of protein formation while preventing protein degradation. Without adequate insulin, protein storage halts, large amounts of amino acids are dumped into the bloodstream, then high levels of plasma amino acids place people with diabetes at risk for development of gout. And changes in protein metabolism lead to extreme weakness and poor organ functioning. So let's talk a little bit about diabetes. Diabetes is a major health problem and a leading cause of death by this disease. So according to the American Diabetes Association, 29.1 million Americans have diabetes. This is 9.3% of the population. 8.1 million of them are undiagnosed and 21 million are diagnosed. Another 86 million people in the US have what they call pre-diabetes. So diabetes is a leading cause of death. In 2010, diabetes was listed as the underlying cause of over 69,000 death certificates and was listed as a contributing factor on an additional 235,000 plus death certificates. Diabetes may be underreported as a cause of death. Studies have found that only 35 to 40% of people with diabetes who died have diabetes listed anywhere on their death certificates. It's a serious chronic disease. Diabetes is the leading cause of new cases of blindness among adults aged 20 to 74. It's the leading cause of kidney failure, accounting for 44% of new cases in 2011. And more than 60% of non-traumatic lower limb amputations occur in people with diabetes. This is characterized by insufficient or absent insulin, or the inability of our cells to use insulin. There are two major types of diabetes. We have diabetes type 1 and type 2. A diagnosis here for diabetes is made on one or more of the following criteria on two separate occasions. Fasting blood glucoses greater than 126, a hemoglobin A1C greater than 6.5%, That's a 3-month average. That's a test that tests for a 3-month average of your blood glucose levels. A 2-hour oral glucose tolerance test, otherwise known as the GTT, greater than 200, and a random glucose of greater than 200 with symptoms of polydipsia, polyphagia, and polyuria. Those are your 3 classic symptoms of diabetes. We want our normal blood glucose level ranges to be 70 to 100. So pre-diabetes, these are individuals with impaired fasting glucose or impaired glucose tolerance or both. These are risk factors for developing diabetes and cardiovascular disease. So we want to educate these patients regarding weight reduction and increased physical activity if that fits what they need in their education to reduce those levels. Typically, you will see that those patients are obese and they're really inactive. And then the diagnostic criteria here for prediabetes is a fasting plasma glucose of 100 to 125, or a 2-hour plasma glucose of 140 to 199, or a hemoglobin A1C of 5.7 to 6.4. And just a little comedy here. So let's talk about type 1 and type 2. So type 1 diabetes, this constitute only 10% of our diabetics. It's formally known as insulin-dependent diabetes or juvenile onset diabetes. And type 2 diabetes actually constitute 90% of our diabetics. It's formally known as non-insulin dependent diabetes or adult onset diabetes. So type 1 diabetes, this is an autoimmune triggered destruction of the pancreatic beta cells. Our insulin levels here are reduced and continue to decline to 0. So insulin here is the key to actually unlock those cells. In diabetics, these beta cells are either attacked or destroyed in diabetes 1 or are unable to produce sufficient amounts of insulin needed for blood sugar control. That would be diabetes type 2. So there's the difference there. So in diabetes type 1, glucose cannot move into the cells without insulin, therefore it stays in the bloodstream. The result here is our elevated serum glucose. The increased glucose causes osmotic diuresis, dehydration, and our body uses fats and proteins for heat and energy, and that will result in ketoacidosis. And remember, we talked about the 3 main symptoms of diabetes being polyuria, polydipsia, and polyphagia. You're going to see that especially in your type 1 diabetics. So here, diabetic ketoacidosis, otherwise known as DKA, is a serious condition that can actually lead to a diabetic coma or even death. So when your cells don't get the glucose they need for energy, your body begins to burn fat for energy, which produces ketones. So ketones are chemicals that the body creates when it breaks down fat to use for energy. The body does this when it doesn't have enough insulin to use glucose, so the body's natural source, which is the body's natural source of energy. So when ketones build up in the blood, they make it more acidic. They are a warning sign that your diabetes is out of control or that you're getting sick. So some symptoms of DKA here, that diabetic ketoacidosis, is going to be, these patients are going to have an extremely high glucose level, probably anywhere from 300 to like 800. They're going to be very fatigued. You're going to see a lot of weight loss. They're going to have fruity odor on their breath, and they will also have what they call Kussmaul's respirations, which are a deep, rapid breathing pattern. And we'll talk more about that later. So insulin is needed for glucose to get inside the cells so that it may be used to make energy. So it's that key that we need to use glucose properly. And without it, then we have big problems. So type 1 diabetes, the age of onset here is usually in childhood. Onset is typically abrupt. Our etiology here, there could be a genetic susceptibility or environmental, examples like viruses, autoimmune, then immunologically mediated destruction of our beta cells, which are our insulin producing cells, or the removal of the pancreas. Our clinical manifestations for type 1 diabetes, they're going to be that polyuria, polydipsia, polyphagia, weight loss, our elevated fasting blood glucoses, frequent infections, a tendency then to develop ketosis, and slow wound healing. So slow wound healing is going to occur because our elevated blood sugar levels stiffen the arteries and cause narrowing of the blood vessels. So narrowed blood vessels here lead to decreased blood flow and oxygen to a wound. So an elevated blood sugar level decreases the function of red blood cells that carry nutrients to the tissue. This lowers the efficiency of the white blood cells that fight infection. So without sufficient nutrients and oxygen, a wound really will heal slowly. So for type 1 diabetic patients, insulin replacement is mandatory. They actually can't live without it because their body doesn't make it or makes very, very little. Oral hypoglycemics here are not effective. Our treatment is going to be subcutaneous insulin, strict dietary control, regular and routine exercise. Diabetic education here is a must. A lot of your newly diagnosed patients will meet with a diabetic educator probably for a day or two, if not a few, and then maybe even do some follow-up appointments with an educator or nutritionist after they're released from the hospital as well. And then they do frequent self-monitoring of blood glucose levels as well. So they're going to need education regarding diet, exercise, blood glucose monitoring, and insulin injections. So these patients also need very close follow-ups with a physician to help them manage their treatment regimen and monitor their A1C levels and their kidney functions very closely. So diabetes mellitus type 1, our signs and symptoms are going to be polyuria, polydipsia, and polyphagia, weight loss, fatigue, an increased frequency of infections. This is a rapid onset with diabetes type 1. They are insulin dependent, and it's an early onset too, typically before 15 years of age is what we see with that. So let's move on to type 2 diabetes. This is our most prevalent form of diabetes. Remember, about 90% of our diabetic patients actually are type 2. The incidence is greatly rising. There's a large number of new cases in adolescents and young adults even, approximately 21 million Americans. These patients do not develop ketosis and the hyperglycemic states because they are capable of insulin synthesis. So this is not to say that they can't develop ketosis, because anybody can, but it would probably be from something unrelated. It would be from something unrelated to the diabetes type 2, because ketosis is a normal metabolic process. So when the body does not have enough glucose for energy, it burns fat instead. This result is the buildup of acids called ketones within the body. So this can happen even when people follow like those really high protein diets, because the body will rely on fat for energy in the absence of carbohydrates, which we would normally use for energy instead of our fat. Okay, so the etiology for type 2 diabetes is insulin resistance and impaired insulin secretion. It can be hereditary. our main factor here is obesity. These patients have a decreased insulin production or faulty insulin receptors, or they could be on long-term steroid use, and that could cause them to have type 2 diabetes as well. They may make some insulin, but it's in decreased amounts. Type 2 diabetes most often occurs later in life, and it is caused by an acquired resistance to the action of insulin or its receptors. So the term insulin dependent has nothing to do with whether a client uses insulin as a medication, but whether the client makes their own insulin. So type 2 patients make insulin, but their body does not use insulin properly. That's actually called, or use insulin properly, sorry. That's actually called insulin resistance. So risk factors here for diabetes type 2, family history, sedentary lifestyle, obesity. Our onset is usually over the age of 40. Hypertension, pregnancy with gestational diabetes, and delivery of a baby greater than 10 pounds. Our Hispanics, Natives, Asian and African Americans, as well as persons of Pacific Island descent are at increased risk. And women with polycystic ovarian syndrome during those reproductive years are 7 times or have a 7 times greater risk. Insulin levels may be low, deficient, or normal, or high where they have a resistance. And then metabolic syndrome can actually be a risk factor too. So metabolic syndrome, otherwise known as prediabetes, this is thought to be a precursor to diabetes. It's characterized by impaired glucose tolerance, high serum insulin, hypertension, elevated triglycerides, and a low HDL cholesterol, and alters size and density of our LDL cholesterol. It's believed that metabolic syndrome is a chronic low-grade inflammatory process affecting endothelial tissue. The long-term effects are atherosclerosis, ischemic heart disease, left ventricular hypertrophy, and type 2 diabetes. Research is directed at learning how to detect this syndrome early and what interventions might slow or arrest the process. So clinical manifestations of type 2 diabetes. These patients may actually be asymptomatic for several years because it's a more gradual onset process. But you're still going to eventually see then that polyuria, polyphagia, and polydipsia. It just won't be as quick approaching as it is with type 1 diabetes. And then, of course, they have an elevated fasting blood glucose levels. They may show frequent infections and slow wound healing and visual changes as well. And remember our normal glucose, we want these patients, our normal glucose is 70 to 100. So treatment for type 2 diabetes is going to be diet and exercise. Those alone may be sufficient to control type 2 diabetes. They could eventually need insulin depending on how well their control with their diet and exercise is. We're going to want these patients to monitor their blood sugars regularly as well. Now, depending on how good their control is and what their physicians order, they may only need a blood glucose check once or twice a day versus that of an insulin-dependent diabetic who may need blood sugars, 4 and 5 times a day. And oral medications, if diet and exercise alone can't control the type 2 diabetes, then a lot of times they'll start with just oral medications, your oral hyperglycemics. And if that doesn't control them, then they'll go to insulin after that. Okay, Complications of diabetes. Acute complications of diabetes is hypoglycemia. This is insulin shock or an insulin reaction characterized by a blood sugar below 60. Our causes here are either going to be too much insulin, too much exercise, not enough food, or maybe they've been sick, they've had vomiting and diarrhea, consumption of maybe even too much alcohol, or childbirth can do this as well. Okay, diabetic patients and their families should be familiar with the signs and symptoms of hypoglycemia. So at the CVS level, the adrenergic level here, you're first going to see patients with tachycardia, palpitations, diaphoresis, irritability, and restlessness. Those may be some of those very first signs that they're going to notice. Or you as a nurse, if they're unable to vocalize that to you, may notice some of those signs as well. And then your central nervous system, the neuroglucopenogenic state, you're going to see confusion, lethargy. They may be slurring their speech. They could even go into a seizure or even a coma. So patients here could exhibit just one or many of the symptoms, or it could really just depend on the level of the glucose as well. Initial symptoms are typically that cardiovascular system symptoms, the tachycardia, the palpitations, diaphoresis. If treatment is delayed, that second set of symptoms may appear, and this is when that central nervous system symptoms kick in, and this is caused by a shortage of glucose to the brain. So treatment here for hypoglycemia, rapid treatment is mandatory. So if hypoglycemia persists, irreversible brain damage or death can occur. They need instant glucose. So we're either going to have to give that by the buccal route or IV if they're unconscious. If they are conscious, though, we can do a fast-acting oral sugar like glucose tablets, orange juice, sugar cubes, honey, corn syrup, a non-sugar-free soda, or 8 ounces of skim milk or 6 to 8 lifesavers. And then we can follow that up with carbohydrates and protein like peanut butter and crackers or cheese. A lot of times in the hospital settings, they'll use graham crackers and peanut butter. So if they're unconscious or if their gag reflex is impaired, we want to do a parenteral glucagon or IV glucose is the preferred route, and it's really, really quick acting, that dextrose 50%. Okay, so for these patients, if they are conscious and we give them that 15 to 20 grams of that quick acting carbohydrates after their instant fast acting sugar, we want to make sure that we're checking their blood glucoses every 15 to 20 minutes until the level's above 70 for adults. And then older adults and children, we want it to be 80 to 100. So if you have that patient who is conscious and they have a low blood sugar and you go ahead and treat them with that fast acting oral sugar and you recheck their sugars and they're good and their tray, like their meal tray is coming up in the next 15 minutes, they should be fine for you to stop there. But if their meal tray is going to be like an hour or so still, that's when you want to add in that extra carbohydrate and protein. So that way it holds them with the hope of holding their blood sugar levels at a normal range until their meal tray does come. But definitely we want to continue to check their blood sugars every 15 to 20 minutes until we know that they're above 70, or like I said, for older adults or children, we want them 80 to 100. So how do we know if our patients need snacks or could have hypoglycemia? There's a saying that says that they're cold and clammy, they need some candy. Okay, so acute complications of diabetes, also that diabetic ketoacidosis, like we talked about a little bit ago, this is caused by an ineffective amount of insulin or an absolute deficiency of insulin, hyperglycemia, and then there's a production of keto acids, hemoconcentration acidosis, and coma can even occur in patients in DKA. This is seen in our type 1 diabetics. The glucose is unable to enter the cell due to a lack of insulin, so the cells are starving, and then the body initiates gluconeogenesis by breaking down proteins and fats, which is actually an abnormal metabolism. This is a life-threatening emergency. When the breakdowns of fats and proteins, the body produces ketones, which are an acidic substance. So as they accumulate, the pH of the blood decreases, resulting in acidosis, which could be fatal. So here again are diabetic ketoacidosis patients. They're going to have a low pH. You're also going to see a low bicarb. If you see ABG results of these patients, they're going to have a low pH and a low bicarb. They're going to show signs of extreme fatigue and those Kussmaul respirations that we talked about as well. Those are those deep, rapid breathing. That's the body's attempt to blow off ketones. That is a sign of metabolic acidosis. They're also going to be dehydrated, so you will probably be doing some replacement of some of their electrolytes as well. This is a mechanism of diabetic ketoacidosis. So diabetic ketoacidosis, so this abnormal metabolism equals a production of ketones, which are acids. The excessive acid leads to metabolic acidosis. Excessive acid is caused by ketones, and that's called ketoacidosis. Precipitating factors here are infection, trauma, surgery, MIs, or an interruption in insulin administration can also make one go into diabetic ketoacidosis. So our etiology here could be an increased intake. Maybe these patients have taken in a super heavy meal and don't have enough insulin to cover that. Or it could be stress linked to things like surgery or just emotional, and it could be related to infection as well. The prevention here is going to be tight blood sugar control. Clinical manifestations of DKA are going to be weakness, drowsiness, lethargy, hypothermia, and tachycardia. Our blood sugars are going to be elevated in that 300 to 800 range. They're going to have a fruity odor of their breath and their urine. They're going to have that large urine output. Glucose and ketones will be present in their urine. And then those Kussmaul's respirations, that's hyperventilation to compensate for acidosis. Polydipsia, dehydration, their pH is going to be below 7.3. They're going to have ketonuria, polyuria. This serum bicarb is going to be decreased as well, so we're going to see a level there less than 15. The mortality rate is 2 to 5% and accounts for half of all deaths in diabetes patients younger than 24 years of age. You will often see this occur in undiagnosed diabetics, but you can also see it occur due to poor management or illness, surgery, or stress. Our treatment here, these patients are going to be dehydrated. So they may have a large volume loss related to vomiting, polyuria, and hyperventilation. So IV fluid replacement and strict I's and O's. They're going to also have electrolyte imbalances, primarily potassium. So initially they'll have hyperkalemia. So we're going to do fluid replacements and of course insulin as well. So these patients will be on an insulin drip initially till they get them under control. Later they're going to be at a risk for hypokalemia. So we're going to do a replacement potassium will be initiated only after adequate urine output is established. So, and then acidosis, these ketones accumulated as a result of the breakdown of fat for energy. So we're going to do a slow IV infusion of insulin, and that will be regulated based on their blood sugar results. So until the serum glucose and bicarb return to normal, they're going to keep the slow IV infusion of insulin going. And then we'll increase amounts of glucose in the fluid to cover for insulin as the bicarb falls. So as your bicarb starts to fall and everything starts to normalize a little bit, then they'll put a little bit of glucose in the fluid to cover for the insulin that the patient is getting. They'll do very frequent finger sticks to monitor that control. They'll monitor electrolytes frequently as well. And then after the patient is stable, then they'll start changing that patient over to some sub-Q insulin. Okay, another acute complication of diabetes is hyperosmolar hyperglycemic non-ketotic syndrome, otherwise known as HHNS. This occurs commonly in type 2 diabetics due to similar causes of DKA in type 1 and especially in the elderly. So patients go into a coma from extremely high blood glucose levels. So these are going to be greater than 600. There's no evidence here, though, of elevated ketones. So the pancreas produces enough insulin to prevent breakdown of fatty acids and formation of ketones, but not enough to prevent the hyperglycemic state. So no ketones are formed and no acidosis results. So persistent hyperglycemia here causes osmotic diuresis, resulting of loss of fluid and electrolytes. So they're going to have dehydration and hypernatremia develop. The mortality rate here, though, is 15%. Usually, initially, it's misdiagnosed as a neurological event, like a CVA. So no ketones are formed and no acidosis results in the HHNS. So for some patients, this syndrome is actually the first sign of diabetes. Others may have been previously diagnosed with what they call borderline or pre-diabetes. These patients don't exhibit the Kussmaul's respirations either because they're not in that acidotic state. They lack of significant lactic acid levels. Clinical manifestations for HHNS is massive dehydration, decreased level of consciousness. They're going to be hypotensive, tachycardic, glycosuria, and polyuria. And again, it's often misdiagnosed as a neurologic problem related to their decreased level of consciousness. So our treatment here for HHNS is going to be fluid replacement, an insulin drip. We're going to have to support their vital functions, so their kidney functions, their respiratory functions. We need to correct the electrolyte imbalances. And here the mortality rate is higher than that of those in diabetic ketoacidosis. Mortality rate for HHNS is as high as 15%, but the treatment is similar to that of DKA. So long-term complications, so chronic complications of diabetes, are going to be due to that impaired circulation, so that peripheral vascular disease, and the collection of glucose in cells and capillary membranes will decrease the transport of oxygen, nutrients, and waste. And then microangiopathy, those microvascular changes are going to cause things like retinopathy, neuropathy, and nephropathy. So retinopathy in these patients, there's vision with diabetic retinopathy versus what one would see in normal vision. So retinopathy here is a damage of retinal vessels, could lead to blindness along people 25 to 74 years of age. Diabetes is the leading cause of blindness. They recommend yearly eye exams. Those eye exams need to be also by a specialist, so an ophthalmologist would better serve those patients. Signs and symptoms that suggest impending eye problems are the presence of spots or floaters in the field of vision. These patients may see cobwebs or have sudden visual changes. Even double vision can be a concern here. Nephropathy. This is a damage to capillaries in the kidneys. The capillaries develop increased permeability and begin to leak red blood cells, albumin, protein into the urine, which are things that we should not be seeing leaking into the urine. It eventually leads to renal failure. So diabetes is the most common cause of end-stage renal disease in the United States. So then extra glucose in the urine serves as a bacterial media. So we'll see these patients be at an increased risk then for UTIs. The reduction of risk here is going to be good glycemic control of hypertension. They may need ACE inhibitors or angiotensin II receptor blockers. Hydration is a good reduction of risk. Early screening and detection as well. And then macrovascular complications. So cardiovascular disease is thickening of a vessel wall, and it makes your blood flow sluggish. Related to a lot of times the hypertriglycerides and floating fats because of the impaired fat metabolism that goes along with diabetes. And individuals with diabetes have a 2 to 4-fold increased risk for heart disease and stroke, which accounts for 65% of the deaths of people with diabetes. So these patients with cardiovascular disease, you may see them have decreased pedal pulses, that claudication, which is that pain in the calf while walking. Severe cases can even lead to amputation. And prevention, to prevent these complications, we want to teach our patients about, of course, weight loss and exercise. And then if they're smokers, we want to talk to them about smoking cessation as well. So neuropathic complications, this is related to poor glucose control, ischemic lesions of the nerves and chemical changes in peripheral nerve cells. They can be classified as mononeuropathy, polyneuropathy, or atomic neuropathy. About 30% of people with diabetes over the age of 40 have impaired sensation in at least one area of their feet. Patients who've had diabetes for over 25 years actually have a 50% chance of experiencing neuropathies. So mononeuropathy affects a single nerve or a group of nerves. Its inadequate blood supply causes a sharp stabbing pain. This pain can be relieved by walking. And then polyneuropathy involves sensory and autonomic nerves. It commonly affects both legs symmetrically. These patients will have tingling, numbness, and burning to complete that loss of sensation. They need yearly foot examinations to test for sensation loss. And autonomic neuropathy, this affects the sympathetic and parasympathetic nervous systems. So here our cardiovascular involvement would include postural hypotension, resting tachycardia, exercise intolerance. If our gastrointestinal system is involved, those patients will have constipation, anorexia, nausea, vomiting, gastric reflux, bloating after meals, gastroparesis, where the stomach dilates and loses muscle tone. So the gastric emptying there is going to be delayed. And if our genitourinary system is involved, they're going to have an atonic bladder, so they're going to have retention and overflow. That is often referred to as a neurogenic bladder as well. And then they may have sexual problems such as erectile dysfunction in men and painful intercourse for women. Okay, so foot complications are also a chronic complication of diabetes. It's associated with neuropathy, inadequate blood supply, or both. So neurologically, our function is impaired and adequate blood flow. So we have impaired function, but we have an adequate blood flow here. So we're going to be warm and pink in our extremities with good pulses, but we're going to lack normal sensations. So they may not recognize injuries. And neurologic function will have adequate function here, but our blood flow is going to be impaired. So our extremities may be cold with weak or absent pulses. And when raised, the foot becomes pale, but when lowered, it becomes red. So injuries may result here from mechanical irritation like rough shoe linings, thermal injuries, chemical irritations that can be caused by substances such as even medicated corn pads. And this actually increases our concerns for ulcerations as well. So we want to teach our patient about the do's and don'ts of diabetic foot care. They need to visually inspect their feet daily. They need to use warm water and avoid soaking. So they need to test the water before submerging their feet, so that way they don't burn their feet. So they want to make sure and test it probably with like their wrist. That would probably give them the best idea of how hot the water really is, because they may not feel that heat with their feet. So they don't want to just put their feet right directly in it. It could cause them to have burns. They want to dry their feet thoroughly, especially between their toes. They need to wear cotton socks and change them daily. Use just mild lotions on the tops and the bottoms of their feet, not between their toes. So they want to use lotions that don't have like alcohols or scents in them. Their nails should be cut just straight across. As a healthcare provider, I don't cut any of my patients' nails for them at all. If the family wants to do that, that's fine. If their nails are cut, we need to teach them that they need to cut their nails straight across. Always wear well-fitted shoes. And any corns, calluses, ingrown nails should really be treated only by a podiatrist. And then do not, for these diabetic patients, do not smoke, do not use hot water bottles, heating pads, or electric blankets. Do not soak their feet in hot water, and don't walk barefooted even inside. This is why diabetic foot care can be so important. We want to educate well to hope to reduce the risk of ulcers, infections, or even amputations in our patients. So prevention of long-term complications, we need tight control of blood sugar levels. We want to maintain our blood sugars within normal levels with medications, diet, and exercise. And then blood pressures as well. We need to maintain blood pressures, a systolic of less than 140 and a diastolic less than 80. And then their lipid goals, total cholesterol should be less than 200, LDLs less than 100, HDL greater than 50, triglycerides less than 150, and then smoking cessation. And then aspirin and ACE inhibitors for those with increased cardiovascular and renal risks. So nursing care of the diabetic patient. So of course we're going to ask them any signs and symptoms if they've had signs and symptoms of hypoglycemia or hyperglycemia. We're going to assess for symptoms of DKA or that HHNS. We're going to ask them about their food and fluid intake over the past 3 days. And then we want to see any home glucose levels if they're available. If they've been checking at home, we want to see patterns there. And we want to ask them about their present medication regimen. Their past health history and family history. Do they have any history of diabetes type 1 or type 2? Any heart disease, hypertension, hyperlipidemia, any renal disease? This could increase their risk for diabetes. And their obstetric history as well. Were these patients, did they have children? Did they have gestational diabetes? Did they deliver babies greater than 10 pounds? And then we're going to do a review of systems. This includes a description of the patient's general health. We're going to note any changes in skin, moisture, or turgor, inquire about visual changes, floaters, double vision, document any significant abnormal symptoms, any leg pain, numbness in their feet. Do they have any ulcerations? And then our functional assessment will explore factors that can affect the person's ability to perform self-care. And then our nursing diagnosis for these patients, ineffective health maintenance, ineffective management of therapeutic regimen, risk for deficient fluid volume, risk for injury, activity intolerance, chronic pain, disturbed sensory perception, impaired skin integrity, disturbed thought processes, and ineffective coping. Teach glucose control, signs of hypo and hyperglycemia, and management of their disease. So we're going to stop this first lecture here. Stay tuned for the second lecture of the diabetes. We'll go over diabetes management more closely in the second lecture. And as always, if you guys have any questions, feel free to let me know.